So let me start by saying that I've been away for a long time, but my name is pronounced Zaborac. For those of you who are over there, you know that. So first, let me also say thank you to Amy for reaching out and asking me to be here. It's an honor and a privilege to come back to my home state and especially speak in front of this group, which I've had some time to catch up with some old friends, and I just really appreciate this opportunity to come back. So thank you for that. And I've been asked to tell our story in 20 minutes, so I will try to do my best to do that. And what I'm going to tell you is our journey so far at the Clay County Public Health Center. We're by no means finished. Or am I ready to have us declared as the Chief Public Health Strategist in Clay County? This journey that we're on is a marathon, not a sprint, but I do believe we are on the right path on the things that we have been doing over the last several years in Clay County. So some takeaways tonight that I hope that I can leave you with. First of all, I realize after seeing the first couple of sessions that I'm going to be repetitive, and that's a good thing, however. That reaffirms, at least for me, that we're on the right track. So forgive me if you hear some things more than once tonight. The first, give you a few takeaways I hope that at the end of this you'll have. The first one is that we must commit to and embrace change if we're going to be the Chief Public Health Strategist. And I say that because of the historic nature of public health. We're all aware of that journey, where we were and where we're now expected to be. So we have to commit to that, I believe. And we have to be fearless, and we have to be, it's okay to fail. Not okay to fail like weatherman prediction failure rates, but somewhere between that and near perfect, I think, it will be good. Remember, plan, do, check, act. And a saying that I like to remember is one of my favorites. I hope it's yours, Yoda. You may remember that Yoda said, how did he say it? Do or do not, there is no try. And that really speaks to the, commit to this process. That's what it's going to take. This account represents a way, not the way, to do this Chief Public Health Strategist. It's one way. It's working for us in Clay County, but I want to make sure that it's understood that the foundational principles are going to be the same regardless of where you're at. It must fit your local public health system, and everybody's system is going to be different, whether that's infrastructure, resources, all of those things. But the foundational principles are the same. The third takeaway I hope to leave you with, it takes time. And unfortunately, there aren't any shortcuts to get this accomplished. So have an awareness of that. Community relations and constant or consistent communication are mission critical. I've found that to be the case throughout our journey. It's not a matter of just saying something or doing something once and then walking away and going, well, we're done. We can put that on the shelf. It's not going to work that way. And then lastly, we take any victory, big or small, and I think that's really important. It's important for us as leaders to help us keep focused. It's important for our staffs so that you celebrate the singles just like you celebrate the home runs, and I think that's really, really important to remember. And there's going to be some days when you strike out too, and that's okay. Before I go any further, I do want to give a special mention to a couple of mentors of mine here in Illinois. They're no longer in the public health system, but Gordon Poquette and Fred Siebenman. Some of you folks may remember them. They taught me the importance of three key components to being a successful public servant. And the first one is communication. The second one is community relationships. And the third is common sense. And I think all of those are very, very important as we try to be the chief strategist. And then I also want to give a special shout out to my friend Kevin Hutchinson, who's here tonight. He's also been a mentor to me. He may not know that, but I used to watch and admire Kevin over the years, especially in the area of communication. I watched and listened and learned, and I was going to tell a story, but the cameras are on, so I won't. But if you buy me a Cabernet in a bar later, we'll talk. Okay. Okay, so a little bit about CCPHC and Clay County's history. When we moved our family there and took the job as Director of Public Health in 2003, there were 182,000 people in the county. Today there are 241,000 people in the county, and it's projected by the year 2040 to be 440,000 people. So this is an area that has seen and will continue to see a tremendous amount of growth. And as that growth happens, as you can imagine, there will be a lot of challenges that have come with that and will continue to come with that. There are 5 hospitals in my jurisdiction, 6 school districts. It's a blend of urban, suburban, and rural. Community sizes ranging from 200 to Kansas City, Missouri, north of the river, and I'll come back to that later, which is about 130,000 people in Kansas City, in Clay County. And Kansas City is spread across 4 counties in the metro area. There are significant industries in Clay County are healthcare and manufacturing. We have, how many people drive an F-150 truck? Only 1, 2? Okay. The F-150 truck is made in Clay County, Missouri. They liked us so much that they built another Ford plant, the Transit van. That's now manufactured in Clay County. So we have that. Healthcare is huge. Anybody heard of Cerner? Cerner's world headquarters are in Clay County, Missouri. So there's a lot of stuff happening in Clay County. We've also seen a significant increase in diversity over the last 5 to 7 years, and I'll talk more about that in a few minutes. So the strategy for us was like building a house. You don't build the roof first, you build the foundation first. And so our 2008 strategic plan really focused on setting the table for us infrastructure-wise. And so, and along about that time, you may have heard of this thing called FAB. That was becoming a known entity. They were developing their requirements, and we had a desire to be an accredited health department, even though at that time we didn't know what the final version was going to look like. But we knew we needed the big 3, which are the strategic plan, the community health assessment, and the CHIP. And so we then significantly invested in our IT infrastructure, because if you, and I'm sure you have, you've went through the Strategist from 2014, that article, or that white paper. Data is king, and as local public health agencies, we have access to a tremendous amount of data, whether it's vital statistics, whether it's your WIC program, whether it's your caseload from various clinical services you may provide. So we knew that with the upcoming electronic health record and health information exchange and all of those things that were starting to come down the pike, that our IT infrastructure was not where it needed to be. And so we invested heavily in that. The Northland, and I said I would come back to that. So, okay, out there, Clay County and Platte County, north of the Missouri River, is called the Northland. Okay, don't ask me why. You would think that river was 20 miles high because you either live north of the river or south of the river. But it's called the Northland. The Northland already had a history of collaboration, but all we did was really expand our efforts into that collaboration. And again, you know, the theme here, as I hope you will see, is tying back into the Strategist issues. And so collaboration was huge, but we needed to up our game, if you will, which we did. And I'll talk about that in a second. There was a collaborative called Vision North. And that was a collaborative that had been getting together since actually the year 2000. So they had been getting together and doing assessments on economic development, education, healthcare, all of those things. So that infrastructure was already in place when I happened to get in Clay County. So that was a huge advantage for us. We also, and some of you may remember this, it was from 2002, but NACCHO had a document out, Making Strategic Decisions About Service Delivery, an action tool for assessment and transitioning. Anybody heard of that or seen that? So we, at that time, that document and that process was about 6 years old. So we undertook that, and that provided an interesting story, which I'm going to tell you, the Reader's Digest version. But we were I guess if you would want to call it that, a prototypical health department when I arrived. We were doing primary care. We were doing dental clinics. We had speech and hearing program with pathologists on staff. And for those of you who've had clinic-based programs, especially for either medically underserved or indigent populations, you know that you don't make money on those programs. You, in fact, you definitely go in the hole on that, right? And I see a few heads nodding, so you know what I'm talking about. We were using about $1.2 million of our public health levy just to keep those 3 programs afloat in our community. And so, you know, I don't believe in luck. I think luck can be defined more appropriately as when preparation meets opportunity. And so we had the good fortune of having a collaborative relationship, not a partnership, relationship, with a federally qualified health center in our jurisdiction. So I approached them and I said, would you be interested in taking these programs from our organization? And they said, absolutely, that's what we were created to do. And so we were able to transition the dental program and the primary care programs to the FQHC and actually charge them rent for being in our building. So it actually went to a positive flow in terms of cash outcomes. So I say that just to give you an idea of the creative ways that you can look at and the collaborative ways that you can look at being a strategist in your community. And every community is different. The resources, as I said, and infrastructure are different, so you have to make it work for how it's set up in your community. So that was our first 5 years. First strategic plan was just getting that infrastructure in place and getting the organization set to potentially move forward. And remember, this was back in 2008, so there was no 2014 Chief Public Health Strategist. And I think I heard you say earlier this afternoon that we've been doing this stuff for a long time. We just didn't call it what we're calling it now. And you know, that really rang with me when you said that. So you guys also might remember, does June 28, 2012 mean anything to anybody? That was the day the U.S. Supreme Court issued its decision in the case challenging the Affordable Care Act on the personal mandate, and they upheld that. So why is that an issue? Well, prior to that, in terms of collaborating, the hospitals, at least in our jurisdiction, they were very competitive, and so they were not terribly interested in collaborating. But once that happened, a couple of things happened. The IRS 990 requirements kicked in for the not-for-profit hospitals, and it's explicitly said that they had to collaborate and work with their local public health agencies. So they were kind of gently velvet glove knocked to the table to talk. And at the same time, in our jurisdiction, we had, like I said, we have 5 hospitals. We have 3 large hospitals and then 2 smaller ones. All 3 CEOs of the larger hospitals retired within 12 months of each other. And so new leadership came in. And so the new leadership, in addition to being new and having had the writing on the wall from the Supreme Court, became much more collaborative, which really, really helped. That was an awesome thing. And so then in 2012, I was at a public health conference in Missouri, and a colleague of mine said he happened to have this book with him, and he shoved it across the table at breakfast, and he said, "Have you read this?" And I said, "What is it?" And it was the 2012 Institute of Medicine's book that one of you guys put up. I think it was you. And investing in a healthier future. And I said, "No." He said, "You ought to read it. It's going to be important." And I said, "Okay." So I got it, and as I went through it, there's a particular chapter that talks about local public health agencies divesting of clinic-based services and moving their resources more into the prevention. And so as a director of public health who just transitioned a bunch of those programs out, I went, whew. That was some validation for what we were trying to accomplish. And so that was really important for us in our discussions during that next strategic planning session. The FAB standards were now in place, and accreditation was starting to happen across the country, and we wanted that very badly for our organization because and this is historic, it has nothing to do with the FAB accreditation. You all in this room can sing to this. We feel like we don't get the respect that we deserve as, in public health and have the seat at the table, so to speak, like we would like. And so, school districts are accredited, hospitals are accredited, why not health departments? And so we were very much wanting to do that. Another thing we did was we reorganized, and you talk about moving the cheese. We've heard that today. We definitely moved the cheese, and that got some people nervous, to say the least. But we reorganized into two divisions, administration and community health promotion. We began to have conversations about developing chronic disease epidemiology because we were already looking at data, and we knew we were going to have to find a balance between maintaining the environmental health and communicable disease programs so that we wouldn't move our focus one way and then all of a sudden all these other things that we thought we had taken care of then started popping back up again. So you have to find that balance between that and moving to where the real disease burden is in this country, and it's chronic disease, as everybody in this room knows. And so the other thing that was new to me, and I had a division director, and one of the things that I've learned as I've gotten older over the years that's really worked well for me is hire people smarter than you and just get out of the way. And that was tough for me as a young administrator because unfortunately I thought I knew it all, and the reality was I didn't. And so I find life to be much easier now that I've hired smart people and stay out of their way. This division director said, we need to be doing this community development thing. And I'm like, what community development thing? Same thing that they're doing at cities and others. They have these community development people, and they're specialists, and they go out and they do this, that, and the other. And I'm like, okay, talk to me some more about that. So she did. And I thought, well, all right, that makes sense to me because I'm trying to actually do that myself as the director. So we incorporated chronic disease epidemiology and community development into our organizational structure. So we really moved the cheese on people. It made people nervous. I don't know how many people have read Jim Collins' book, Good to Great. Anybody read that? And so, one of the things he talks about is getting the right people on the bus, right? And sometimes you got to move people from one seat to another, and sometimes people need to get off the bus. But in order for us to go forward, we had to have those conversations, and we did it I hope and I feel like we did it in a professional way, and we tried to explain everything. But if you're going to move your organization forward, sometimes you just have to do those things because it's just necessary if you're going to be successful. So we begin to then invest significantly in workforce development and community development. So we started sending our staff to training for evidence-based decision-making, performance management, quality improvement. We were very lucky in Missouri, and I've already heard it mentioned, I think, tonight. Wash U, Dr. Ross Bronson, anybody heard of him? Yeah. So he was kind enough to bring his evidence-based decision-making training up to the Kansas City area. And so another way to creatively approach this, we hosted that, and we hosted it as a regional training, and we charged people to come to our facility, and so it ended up paying for our staff to be able to attend that meeting. But he brought that up there to the Kansas City area. So the point there was evidence-based decision-making, PMQI. We were starting to ingrain those into the culture of the organization. And by the way, speaking of the organization, I want to make it clear to the group that we're no different in Missouri than you are in Illinois. I've been following Illinois, even though I've been away for almost 15 years now. We have the same issues in Missouri. The infrastructure. By the way, Kentucky, you're 50th. Guess what? Missouri is 50th in the United States in state funding for public health, and so we got you beat on that one. But we had some real challenges over the course of time. When I first arrived, and I know this sounds terrible to say, when I first got there, we had 91 staff. We're down to 55 now. And so the point is, I know this is a national, and I think he talked about that also, the national trend for the depleting public health workforce. And so we're experiencing that as well. But in terms of moving the cheese, we knew we needed community development folks. We convinced our community health education specialists, the CHES folks, to eat the cheese, if you will. And so we sent them to the University of Missouri Community Development Academy, and they went through about a year and a half worth of training to be community development specialists. So they were having more skill sets added to them, and they were filling a need in the organization. So just another example of how you can creatively approach these things, because it is tough to do. We created a health policy planning section, which is really the engine for our growth going forward. The health policy and planning section is the data section, and so they're the folks that enjoy all the numbers and crunching numbers and putting things together and telling you, well, this is what this means for our community. So we invested in that. We created a chronic disease epidemiology position. And by the way, we were able to do some of these things because of what I said, by making those tough choices about reorganizing and divesting out of the clinic-based services. We didn't have a whole bunch of new money coming in. So that I want to make that very clear. It's about being creative for sure, because we all know we don't have a lot of that funding coming our way. I stole, full disclosure, family case management from here in Illinois. I was a big fan of that. I was an administrator when that started in 1991. It used to be called Healthy Moms, Healthy Kids. You remember that? And is it still Cornerstone software? Yeah. Well, interesting enough, that didn't change, did it? Everybody still hates that thing. So we implemented that family case management model, if you will, even though we don't have Cornerstone and we don't have the support of the state health department. So we used our own resources to do that, and that was a challenge. But our staff believe in it because we're seeing improved health outcomes, and that's really why we exist as a public health entity, is to improve the health outcomes in the communities that we serve. So we've got that going. One of the areas of weakness, it's been a historical weakness in my opinion in public health, is telling our story. People don't know what we do, and you've been in a community for 50, 60 years and they still don't know what you do. Shame on us. But that happens everywhere. So we invested in public relations and communications. We actually created a position for that. And so I don't do any of this stuff, this Facebook and Twitter and whatever else people do nowadays. But we've got a person who just goes gangbusters on that, and they help get our messages out all day long, every day. The other thing that we did, and you may recall from earlier where we talked about in the last 5 to 7 years in our community, We had a significant amount of immigration that occurs. So as we're looking at everything, we see we're having the chronic disease issues. We created this organization called DACHI, which stands for Diversity Advisory Council on Health Equity, and it was created specifically for the diverse communities that we have. We're seeing a significant increase in a number of ethnicities in our jurisdiction as it continues to grow. And so this was put together to be responsive to their needs and concerns. And I can tell you that I had no clue how diverse our county was until we started that effort. We have people from all over the world emigrating to our county monthly. From all over the world, not just certain areas of the world. It was just truly eye-opening. So we created that, and that's also a touchback to the Chief Health Strategist. I forget which number it is, but you can look that one up. So let's fast forward to 2015 because I've got about 3 minutes left, I see. So in 2015, the Northland engaged in a collaborative effort. We created this Northland Health Alliance, and it's a partnership with the 5 hospitals, the mental health agencies, a group called Northland Healthcare Access, which is an access to care organization, the 3 health departments in the Northland, and social service agencies, and they all came together to help us, Clay County, create a 2015 community health assessment. And that was the first time, believe it or not, that hospitals sat at the same table and shared their data. Now these are hospitals that were very competitive. Hospital service area is different than a local health department service area. And these hospitals came together, they shared their emergency room data and their admissions data at the same table. I was pleasantly surprised, pleased, but shocked that they would do that, but they did. And that was incredibly helpful to help us form our community health assessment, which resulted in behavioral health, access to care, and chronic disease as our top priorities. Shocker, right? And then we created a 2015 CHIP with SMART goals. We use a performance management software called iBossWell that is a stoplight, and we track those. And we meet regularly. The task forces meet monthly. The Northland Health Alliance meets quarterly to review progress on that. All of that allowed us in 2015 to become one of the first 100 health departments accredited in the United States. Very proud of that effort. And then very quickly in 2018, here's what's happening now. Just last month, the Northland Health Alliance decided that we should become incorporated as an entity in Missouri. So this is a really big deal. So we went from just sharing information to now we just got our articles of incorporation last week in Missouri. And they want to be a 501c3 organization, so we'll be applying for that, which means we'll be able to apply for funding. This effort has really morphed over the course of time, and it's going to allow us to do a lot of these things, I believe, going forward in the Chief Public Health Strategist arena. So the rest of the stuff happening this year, we're doing a new CHA, a new CHIP, a new strategic plan, and on the health department front, we've just implemented Microsoft Office 365, for those of you who are familiar with that. I'm very old school. I learned the hard way at the Illinois Department of Public Health in 1980, I don't know, 8. You know, these computers that they're putting on our desk, you probably ought to learn how to use those. They're going to be important someday. And I was like, really? You think? Yeah, you better learn how to do it. So I did. And then we're getting a new financial software package, and the reason why I mentioned that is that financial software package, we're currently, I won't say the name because I don't want to get in trouble since we're being recorded, but this new software package is going to allow us to track the hours and the expenditures per each area of our community health improvement plan. So we're going to be able to track how many hours and how much investment we're making in our community in behavioral health. How many hours and how much time we're investing and money we're investing in access to care. And the same thing for chronic disease. And so as a leadership team, it's going to give us a great balcony view of how we are moving the needle on public health in our county. So that leaves 30 seconds, I think, if I did that right. So that's very quickly. That's the Reader's Digest of our version. I've been very fortunate and very blessed in my career. If people like Kevin would have retired earlier, I wouldn't have had to leave this state. But there were no openings at that level when I was around. So anyway, thank you all. I hope it's been helpful.